a very contemporary topic today, which is the use of cell-free DNA for fetal Rh genotyping. And Keely is our senior fellow. She's gonna educate us a lot today. I also want to tell everyone that I think today is the first day where I have 10 of our own genetic counseling students at Jefferson also attending fetal therapy. We're having 10 students a year. The 10 new students are joining us today. Welcome to the new genetic counseling students. And I do apologize. I have a medical student lecture at around 10 o'clock, so I will be leaving soon. So in case you miss my comments at the end, but please, Amanda and Vincenzo, make sure, to basically guide the presentation towards the end. And thank you, Keely, for working on this very contemporary and challenging topic. I think there's so much for us all to learn from.
Dr. Al-Falali, she inspired me to focus on this topic for this fetal therapy. If you've gotten the Green Journal in print anytime recently, you've seen Natera's advertisement glued to the front about fetal Rh genotyping using cell-free DNA. And so I think it's something useful to discuss. And Kavisha's had a really great intro for us. So there's entire textbooks on blood groups. And the background of this presentation is in no way meant to be comprehensive. A lot of this is like med school level knowledge that we'll just, briefly touch on. But I think it's important to kind of get a baseline understanding and conversation starter before we discuss fetal RhD status. So in a historical perspective, prior to the 1900s, it was thought that all blood was the same. And then human blood groups were discovered in 1900. In 1901, Karl Landsteiner at the University of Vienna observed that blood serum of an individual would agglutinate with only those of certain individuals. So based on this, he classified human blood groups into 3 groups, A, B, and C. It was very political and there's a lot of history that goes into it, but eventually group C became group O. So we say, in around 1901, the ABO blood group was discovered. And then in 1940, there was the discovery by the same person of the Rh blood group. By the 1950s, the ABO system was universally followed. Any newly discovered antigens were named alphabetically, like ABO, or by the person that founded them. So Duffy, for example. In 1980, the International Society of Blood Transfusion created a committee to establish numerical terminology for red cell antigens. So it's just important to know that because you may see it referred to in numerical terms. Each blood group antigen was assigned a 6-digit number with the first 3 digits representing the blood group and the last 3 the antigen. And just interestingly enough, for example, the A antigen was the first to be discovered, and so it has the number 001.001. The B antigen was the next, and so it's 001.002. In 1991, the gene for RhD antigen was discovered. So just a little brief med school level background, or even maybe high school biology. Red blood cell membranes contain many surface proteins called antigens, and majority of blood group antigens are glycoproteins. A blood group system consists of 1 or more antigens controlled by a single gene or by 2 or more linked homologous genes. According to the International Society of Blood Transfusion, as of December 2023, this is constantly updated, but as of December 2023, there are 45 blood group systems that contain 362 red cell antigens. And so technically, a complete blood type would actually describe each of the 45 blood groups. But as we all know, we're usually saying, A positive, O negative, and that's what we focus on mostly. 50 genes have been identified and sequenced. In terms of red blood cell antigens, so we know that an antigen is a substance that can elicit an immune response. Blood group antigens are sugars or proteins on the surface of red blood cells. So antigens of the ABO blood group are sugars. Antigens of the rhesus or Rh blood group are proteins. Antigens found on red blood cells determine one's blood type. So we have ABO, and we refer to positive or negative in terms of the patient's Rh status. We know that ABO blood groups vary between populations. This graph just represents the distribution of ABO phenotypes by race or ethnicity. So for example, the highest percentage of type O, 57%, was found in Hispanic donors. The next highest percentage of O was found in North American Indians, 55%, and then Black at 50%. And so we do see a difference based on race and ethnicity. And it's believed by many that this geographical variation of blood types may be secondary to genetic selection, as I'm sure you remember learning about. So for example, certain antigens may confer resistance to particular diseases in certain regions of the world. So this is seen with blood type O in malaria endemic countries. Individuals that have type O have the highest rates of survival. And then we'll kind of jump into Rh antigens. So we know Rh antigens are found on non-glycosylated transmembrane proteins on the red blood cell membrane. There are more than 50 Rh antigens that have been identified, but most commonly we're referring to RhD, big C, little c, big E, little e. RhD antigens, which is the focus of this topic, or this presentation, are expressed on fetal red blood cells by 38 days gestation and are only present on red blood cells. Some antigens are present on other things. RhD positive patients have the presence of the D antigen, while RhD negative have the absence of the D antigen. So we know about 85% of people are positive, while 15% are negative. And this is just in North America, because again, we have that geographical distribution. Around 60% of RhD positive individuals are heterozygous for the RhD antigen, so big D, little d, while 40% are homozygous for the RhD antigen. In terms of the genetics, the RhD antigen is encoded by the genes RhD and RhCE on chromosome 1. Individuals may have the absence of the RhD antigen secondary to absence or alteration of the RhD gene. So we know that most RhD negative individuals actually have a complete deletion of the RhD gene on both copies of chromosome 1. And so they're homozygous for the RhD gene deletion. And this is the most common genotype. However, there are more than 200 gene variants that have been associated with alterations in the expression of the RhD antigen. So some individuals have an alteration in the gene that leads to a non-functioning RhD gene. And then we have RhD pseudogene and RhD hybrid gene. RhD genotype and phenotype can be discordant, so it's important to understand that. And examples of this include weak D and partial D, which that could be a whole separate lecture on its own, so we're really not going to get into that today.
So Keely, can you go back to that slide? So basically, really, it's very important for the MFM fellows and the genetic counseling students to know that when we say someone's blood is A negative or O negative, the negative comes from the fact that that individual likely have a deletion on or an absence basically of that particular gene, as Keely have mentioned, on chromosome 1. And honestly, I think most of us we don't know this information. I didn't know this information until I did my genetics training. So I think this is fascinating to just think how, a deletion in that particular gene actually accounts to a blood type being, like, say, O positive versus O negative. So that's amazing. And hopefully the fellows will always remember that.
And we'll dig in a little bit more to this, but this is a critical slide in understanding why we haven't been using non-invasive prenatal testing or cell-free DNA in the United States up to this point for RhD genotyping of the fetus. And so this is just another way to look at it. Like Dr. Alquatli said, we're looking at chromosome 1. If a patient is Rh positive, we're seeing that they're expressing this RhD gene. They could be homozygous, heterozygous. Then we're seeing Rh negative. They may be homozygous, so have complete deletion of, genes on both chromosome ones. Then you can have a pseudo gene where you're only having deletion of the gene on one of the chromosomes. And then you can have hybrid genes where you're kind of seeing a combination of the RhD gene and the RhCE gene. So another thing that's important to understand when we're talking about creating assays that would test for this. So just like ABO groups, the prevalence of RhD negative phenotype is varies by race and ethnicity. So we know 15 to 17% it is seen in our 15 to 17% in patients of European or North American descent, 3 to 8% in Africa and India, really low numbers in Asia. And just interestingly enough, the highest rates of the RhD negative phenotype are actually found in northern Spain and southern France. Maternal RhD typing and antibody screening. So obviously standard of care is to identify the ABO blood group, RhD antigen status. So like Dr. Alcalay said, our plus negative, when we were referring to plus negative, and red blood cell antibodies with serologic testing at the initial prenatal visit, which ideally you're doing this in the first trimester. And then it's recommended to repeat antibody testing for all unsensitized Rh negative patients for any sensitizing event in pregnancy at 24 to 28 weeks gestation and at delivery prior to administering anti-D immunoglobulin, which we'll talk about. RhD testing is critical in pregnancy because it allows for the opportunity for prevention of alloimmunization. And this is crucial because we know exposure of RhD negative patients to an RhD positive fetus may result in hemolytic disease of the fetus or newborn, which obviously causes fetal anemia. And then of course we care about blood type because it's also important in the event that a mom needs a blood transfusion. So when we're talking about RhD alloimmunization, we're referring to a immunologic process in which antibodies are formed to foreign cells. And so most commonly it occurs in pregnancy and with blood transfusions. The Rhd antigen accounts for about half of all alloimmunization in pregnant patients. But of course, as we were discussing earlier, there are a number of other antibodies that can be tested for that can cause alloimmunization. So maternal Rhd alloimmunization develops secondary to Rhd negative mom exposure to Rhd positive fetal red blood cells. So if a patient is exposed to the antigens not present on their own blood cell, an immunologic response ensues with formation of IgG antibodies against the foreign antigens. A fetus with the presence of Rhd antigens exposed to maternal cells that have absence of Rhd antigens can result in formation of the antibodies. That's repetitive. But essentially these antibodies can attack fetal red blood cells in future pregnancies. So what are the causes? So fetal maternal bleed. This accounts for virtually all cases of maternal Rhd alloimmunization. However, the actual cause of the bleed can't be identified in most cases, and some studies quote up to 80% of cases we can't actually identify. Of course, transfusion could be a cause. Deliveries that could lead to fetal maternal hemorrhage, like cesarean delivery, vaginal delivery, spontaneous or induced abortions could, ectopic pregnancy even could, certain procedures like diagnostic procedures, even aversion, IV drug use, trauma, these could all result. So factors that determine occurrence of maternal Rhd alloimmunization. So first, it's believed to be the frequency of the sensitizing event. So for example, how often is this fetal maternal bleeding occurring? Secondly, volume of fetal maternal bleeding. So we know that the risk increases with advancing gestational age and is highest at delivery. In some individuals, it's been found that as little as 0.1 milliliters of Rhd positive cells is enough volume to immunize, while others, 15 milliliters of exposure didn't cause sensitization. So we're definitely seeing differences in each person. There's some studies that have looked at ABO compatibility and the occurrence, as well as maternal immune response. And so we know that there are decreased rates of sensitization in patients with age, patients undergoing chemotherapy, patients that are on immunosuppressive drugs. And so there are several factors that determine whether a primary immune response occurs. And this is just a nice schematic and kind of goes to exactly what we were talking about earlier with our patient prior to this presentation. How exactly did she become immunized? But essentially the typical scenario is you have your first pregnancy, you have your mom who's Rh negative, you have your father who's Rh positive, and the baby's Rh positive. And there is some sensitizing event or, fetal maternal hemorrhage where the mom's red blood cells are exposed to the baby's red blood cells. And what we see is formation of anti-Rh antibodies. And then in subsequent pregnancies, what we're seeing is these antibodies are IgG, so they can cross the placenta and attack baby's red blood cells essentially and lead to fetal anemia. And we'll talk kind of recap on that in a second. So how do we prevent it? That's where RHD immunoglobulin came in. So we know that administration of RHIG, also known as anti-D immunoglobulin, was first introduced in the late 1960s, early 1970s, and it stopped the formation of anti-D antibodies in RHD negative patients. And we saw a pretty drastic reduction in alloimmunization in at-risk pregnancies. And so it was reduced from 13 to 16%, all the way down to about 0.5% to 1.8% when it was administered in the postpartum period. And then there was the addition of administration, around that 28-week mark during the antepartum time. And it decreased that rate even further to less than 1%, at most maybe 0.2%. And so we know that there are multiple licensed sources of RHD immunoglobulin in the US. Listed here, RhoGAM is the one that we often refer most to and use.
But we used to have Rofilac for many years. We still have Rofilac?
I think that's what we use here.
I think that's what we use here.
Yeah, and Jeff, we don't
We've been
use.
using
Rogaine.
Rofilac for
We use-
15 years.
So
Yeah, no, that's why that's why everyone is using race like RHIG and stuff.
we know that this binds specifically to the RHD antigen. 300 micrograms of RhoGAM, for example, covers about 15 cc's of red blood cells or 30 cc's of whole blood. And importantly, we've seen that prophylaxis has significantly reduced hemolytic disease of the fetus and newborn. And that's why it's the standard of care. And we give RHD negative patients, this at the time of a sensitizing event prior to any invasive procedure, potentially around 28 weeks and within 72 hours of delivery if the neonate is RHD positive to prevent the sensitization. So when we talk about hemolytic disease of the fetus and newborn, this is kind of just driving the point home. We touched on it briefly a couple slides ago, but essentially these anti-D immunoglobulin antibodies are present in the maternal circulation and put the fetus at risk for hemolytic disease. And so we know that these IgG antibodies cross the placenta, opsonize fetal red blood cells. These are phagocytized by macrophages in the fetal spleen that results in destruction of fetal cells and then result in fetal anemia. And we know that the antibody concentration and transmission of antibody to the fetus influences the severity of fetal anemia. There are multiple other factors that have been shown to potentially influence the severity of disease in the fetus, including subclass and glycosylation of maternal antibodies, the structure, size, density, tissue distribution of blood group antigens, efficiency of transport of IgG, function of the fetal spleen or maturity of the fetal spleen, polymorphisms that affect certain receptors, and HLA related antibodies. So what do we see? What are the fetal effects of HDFN? It can result in extramedullary hematopoiesis. We can see clearance of fetal red blood cells, obviously fetal anemia, which then can result in high drops, heart failure, high levels of bilirubin that can lead to connectorus and fetal death. So how do we assess fetal Rh status? We understand that fetal anemia can occur if the mother is alloimmunized, but what do we do about it? We need to assess the fetal Rh status. And so we can do this through several approaches. The first option is to check paternal antigen status. And so partner testing with paternal blood type and genotype if father of the baby is Rh positive. And so we know if the paternal blood type is negative, then the fetus is negative. Mom's negative, dad's negative, the baby's negative. However, if the paternal blood type is Rh positive, dad could be homozygous, so DD, big D genotype. And so we know that baby is going to be Rh positive. However, dad could be heterozygous. And so there's a 50% chance that the fetus is Rh positive. We also can do fetal antigen genotyping through diagnostic testing, so amniocentesis for fetal Rh status. And then what about cell-free DNA? Maybe. Doing CVS is discouraged due to concern that it could provoke potential fetal maternal hemorrhage.
The patient's already sensitized.
What is the chance of maternal placenta hemorrhage with an
Amniocentesis?
placenta versus non? Or accordocentesis? Like you said, there is discouraged because increased risk of maternal hemorrhage.
Yes.
CVS, not amnio.
What is the chance?
I don't know what I don't know. I think it's a theoretical concern.
No, there are reports.
I don't know.
They're all reports. Because again, you're in the placenta, you're mixing mother and fetal, so it makes sense. There's a little bit of blood, obviously, at 11, 12 weeks. But there are reports of increasing factor, the risk of anemia, etc. No,
We do that. We do amnio because we don't do CVS because of that, and we do amnio. Just briefly, because it says fetal therapy, so defining fetal anemia. It's defined by hemoglobin or hematocrit levels. The hemoglobin levels more than 2 standard deviations below the mean is diagnostic. Fetal hemoglobin reference ranges are based on gestational age. Hemoglobin values increase with advancing gestational age. And so Dr. Al-Khwatli was telling me that this brought back memories for her because she would refer to this so often. So historically, to detect fetal anemia, serial amniocentesis could be done, and this was essentially to evaluate levels of fetal bilirubin. Spectral analysis at 450 nanometers wavelength. The results were plotted as a change in delta 450 on specific curves or graphs. This is a Wiley graph, which was referenced a lot back in the day when this is how we monitored fetal anemia. Also,
did that in medical school and first residency.
you did that?
Yeah.
Then there's the option of serial pubs. Obviously, there's risk to that, but that's another way that you could kind of monitor fetal red blood cell levels. And thankfully now we have MCA Dopplers. So a study published in the New England Journal of Medicine in 2000 found sensitivity for MCA PSV for moderate anemia and severe anemia with or without high drops to be 100%. There was a 12% false positive rate with a positive predictive value of 65% and a negative predictive value importantly of 100%. So management of alloimmunized pregnancies is outlined in SMFM's 2015 clinical guideline that Dr. Bergella wrote. First, we remember we have to remember there has to be enough antibody. And if we don't know paternal or fetal status, we perform serial titer checks every 4 weeks, more frequently if obviously titers are rising or as we advance in gestation. Critical values are lab dependent. Or titers are lab dependent, but usually 116 or 1 in 32 are considered a critical titer. If they surpass a critical titer, it places the fetus at risk for development of severe anemia or high drops. And so traditionally MCA Doppler is initiated. And ideally you determine paternal genotype or fetal Rh status. And if it's negative, you don't need to do any further surveillance, but this isn't always possible. And so MCA Dopplers are the way to go in these cases. In approximately 35 to 50% of pregnancies with alloimmunization, the fetus is antigen positive and at risk for hemolytic disease of the fetus and newborn. However, that means, all the way up to 65% of pregnancies, the fetus is actually negative and not at risk. And again, just because it's fetal therapy, briefly, MCA Doppler assessment, we know that fetal anemia can be detected on ultrasound with MCA Doppler assessment. We know that an increase in the MCA systolic velocity occurs as fetal hemoglobin decreases. MCA PSV of greater than 1.5 multiples of the median is used as a screening test to identify a fetus with severe anemia. And significant risk for fetal anemia is seen in fetuses with an MCA Doppler greater than 1.5 multiples of the median, or if the baby's hydropic. And so how do we accurately measure MCA Doppler? Axial section of the fetal head at the level of the sphenoid bones during fetal rest. It's important that the fetus is at rest and not moving because that will alter your result. You want to image the circle of Willis with color Doppler. You select the area of the MCA close to the transducer. You want to visualize the entire length of the MCA. You want to zoom in. It should occupy more than 50% of the image. You want to sample as close to the origin from the internal carotid artery as possible. And then you want to keep the angle between the direction of blood flow and the ultrasound beam as close to 0 as possible. And then this is just for your reference. Yep. Let's try and.
When measuring the middle cerebral artery, you need to rotate a little bit to keep the artery completely very, very vertical. So his picture is a little bit rotated and go a little bit this way. Keep them completely vertical to your color.
So you have that
That angle,
0 degree.
0 degree.
And important to know that you're going to repeat this at least 3 times because their measurement isn't perfect and you're using your highest MCA PSV for your decision making. And we know that we see reduced velocity or falsely lower MCA PSVs if one, the fetus is moving, you measure at a more distal aspect of the MCA or where that angle is not 0. And so. Severity of fetal anemia.
So you always need to correct the peak systolic value to the gestational age. So you need to use the algorithm of the table to determine what is the normal MOMs. You use the MOMs to determine whether you want to do therapy or not, instead of your peak systolic value. So you always need to transform it into a corrected zone by the gestational age.
So we know that severity of fetal anemia is based on hemoglobin concentration. We know that severe anemia can lead to high drops and fetal death. And we know that a history of a previous affected fetus or newborn increases the probability of subsequent affected RHD incompatible fetus to more than 80% when we're talking about RHD in particular. So kind of back to the prevention of fetal anemia, RHD immunoglobulin. So the FDA announced that there was a shortage of RHIG in December of 23, and this was thought to be secondary to issues in the anti-D plasma market and manufacturing deviations, and they stated that it was expected to last through 2024. So ACOG came out and released a practice advisory in March of 24 in response to the FDA, and suggested that other RHIG products be considered as an alternative to RhoGAM, which it sounds like, Jeff, we don't use RhoGAM. We use one of those other products that they referenced. And then in April of 2024, they actually updated this practice advisory secondary to continuing decreased supplies. And they suggested that cell-free DNA be considered to determine RHD status, essentially to conserve our RHIG supply. So this was the statement. They said if shortages persist, you could consider umbilical cord blood collection at the time of delivery, which is done in most places. Don't give RHIG to RHD sensitized patients. Don't give RHIG if paternity is certain and the father is Rh negative. These are like, this is what it said. Very obvious. Prioritize postpartum patients over routine 28-week antepartum administration, and question mark, determine the fetal Rh status with cell-free DNA. And this was kind of what the updated statement in April said. So although current ACOG guidance does not recommend routine use of NIPT to determine fetal RHD status based on cost effectiveness analyses, the use of NIPT to prioritize use of RHIG and conserve RHIG supply is a reasonable consideration in the practice setting that is experiencing shortages. Non-invasive fetal red blood cell antigen genotyping utilizing cell-free DNA isolated from maternal plasma has demonstrated high sensitivity and specificity for detection of fetal RHD antigen status. If cell-free DNA testing results confirm an RHD negative fetus, then RHIG would not need to be administered. So what to do in light of the shortage? NIPT, question mark? So let's talk about it for a second. So NIPT for determination of fetal RHD genotype. So non-invasive prenatal testing of cell-free DNA can be used to determine fetal antigen genotype for the prediction of fetal antigen phenotype. Cell-free DNA to determine fetal RHD genotype was actually first described back in 1993. And this is actually done in many European countries. So the use of cell-free DNA PCR testing guides the administration of RHIG and is the standard of care in many European countries, including Denmark. They were actually the first country to implement cell-free DNA for RH, and that was back in 2010. Also used in the Netherlands, Belgium, England, Sweden, France, Italy, also used in Australia and New Zealand. So like I said, it determines who receives RHIG. It can guide pregnancy management for allo-immunized patients. So like, why are we not doing this?
We're so behind.
Huh?
We're so behind.
So behind, like, what are we
These
doing?
issues.
Like,
Crazy.
we're like so behind.
Yeah.
We need to catch up. So the history of NIPT for RH in the US, there was actually an assay that was developed back in 2010 that was called Sensagene RHD genotyping, and there was a prospective trial of 120 non-allo-immunized RHD negative patients. There was only one false negative out of 349 samples that were, and there were only 349 samples that were deemed reportable. There was a 6.3%. 6.3% of samples were inconclusive and not reportable. However, in 2013, there was a cost analysis on the use of this for RH typing. To selectively, they were looking at selectively delivering antenatal and postnatal prophylaxis with our RHIG for prevention of alloimmunization in RHD negative women. And they estimated that the cost of this assay or test would need to be decreased by $119 to be equivalent to the current standard of giving RhoGAM. And so several years later, the assay was discontinued, and it was never really, there was never really like an uptake of it, and we didn't do it. So why are we not doing it? So it's important to understand that the technology that is used in Europe cannot be used in the same way in the United States, and we'll get into why. So first, there are some downsides to it. So often the testing isn't done until after 20 weeks gestation. And so, you're catching it late in the game. The European SNP-based NIPT assays lead to high rates of no result or inconclusive results. And this is really the most important point to drive home, is that the assays that they use are not useful in certain non-deletion genotypes secondary to the PCR technology. And the technology that's being used in Europe assumes that the fetus is homozygous for the RhD gene deletion. And as we talked about at the very beginning, yes, we can have a deletion of the RhD gene, but we can also see pseudogene, hybrid gene. There are other genetic alterations that can occur, and these assays are not evaluating for those. And so so it's not useful in a non-European ancestry, because as we discussed, we know that the gene alterations vary by region in the world and by race and ethnicity. And so up to 30% of RhD negative Black patients and 60% of African patients have a non-deletion RhD gene variant, for example, like your pseudogene. And so these technologies are not going to pick this up. There's also the risk of false negatives. The test, interestingly enough, doesn't directly measure cell-free DNA, but instead detects the Y chromosome genes for a single autosomal reference gene, which is a little bit above my head. But it leads to inaccuracy secondary to sex bias. It increases the risk of false negatives. And it's especially less, there's more false negatives if the test is done in early gestation, or no call results really due to a lower fraction of cell-free DNA. And then, as we discussed on the previous slide, it's not been proven to be cost-effective in the US. Most importantly, you're not going to catch all the cases, and that's the problem. So before we jump into two companies that have kind of come up with new ways of assaying RhD genotype, I want to just briefly discuss using next generation sequencing. So the current assays that we're going to talk about for RhD genotype uses next generation sequencing. And so what is this? Essentially, the maternal blood sample is obtained and cell-free DNA is extracted. This is both maternal and fetal DNA, right? Then PCR technology uses primers to amplify specific regions of the target DNA and creates multiple replications of the target gene. These are called amplicons. Then it simultaneously is used to sequence the amplicons. And then these sequenced amplicons are analyzed to determine the region of gene and the number of molecules of specific regions of the gene to determine the actual genotype. And then algorithms and bioinformatics essentially interpret these results. And so Billion to One came up with Unity Fetal RhD non-invasive prenatal test that they claim can determine fetal RhD genotype. Billion to One is headquartered in California. It's a diagnostics company, and they patented this technology that we'll briefly discuss called QCT, or quantitative counting technology. And that is how we'll get into that. Just to kind of look at what Billion to One offers, it can test for certain recessive conditions. Obviously our aneuploidy screen, and then we have now these antigen tests. So there was a study published in August of 23 in Scientific Reports that looked at the validation of non-invasive prenatal test for fetal RhD, as well as other Rh antigens, big C, little c, big E, et cetera. Important to note that the majority of authors of this Unity study are employees of Billion to One, or hold stock in Billion to One. But essentially they developed and validated a next generation sequencing based non-invasive prenatal test assay that uses this quantitative counting template, so QCT technology, to detect fetal antigen genotypes from maternal blood samples. And they claim that, this was done in an ethnically diverse US population. And we'll kind of get into what they high points, because we don't have time to dig in deep to each of these studies. Okay. So, they kind of background state that RHIG is unnecessary in approximately 40% of RHD negative pregnant individuals who carry an RHD negative fetus. Because they carry an RHD negative fetus. They say that decrease in the need for RHIG is desirable for many parts of the world, especially where there are shortages, and that clinical adoption of NIPT for the detection of fetal antigens for both alloimmunized and RHD negative, non-allo immunized pregnant individuals may streamline care and reduce unnecessary treatment, monitoring, and patient anxiety. So again, they developed this next generation sequencing based assay. But it's important to note that there was clinical validation that occurred after large samples and analysis, and it included only 23 RHD negative pregnancies. Okay, so what is QCT technology? It may be useful in the US population. It's a molecular counting platform created by Billion2One. It quantifies genes of interest and sequences variants using next generation sequencing. And it's been previously validated for autosomal recessive diseases, so like cystic fibrosis, for example. It allows for identification of small changes within DNA in comparison to larger changes that were traditionally detected by non-invasive prenatal screening. So these small changes result in small fragments and a background of a lot of maternal DNA. And it can quantify these DNA fragments to detect tiny DNA variations. So very, very briefly, essentially, the first step is they add a specific number of traceable synthetic DNA fragments called QCTs. Then they amplify using PCR. Then they count. So they count the number of QCTs in the amplified sample and divide it by the number added to the original sample. And this is the amplification multiplier that they use. They apply the multiplier from the QCT's amplification to solve the number of DNA fragments of interest in an original sample. And it's, again, a little bit above my head, but this is the technology that's being used. And this schematic just shows that it's a good way to kind of represent. The assay is comprised of 5 amplicons across the RHD gene. So we're looking at the RHD gene. These gray marks are amplicons, and they amplify regions that are unique between the RHD gene, the RHCE homolog gene, and the pseudogene. So the problem with the initial test, or the test that Europe uses, which is appropriate for their population, is that it was only looking at this RHD gene. But now this assay, in a very complicated way, can look for more than just that gene deletion. So the study stated that the assay correctly determined fetal antigen status for over 1,000 preclinical samples with a sensitivity of 100%, specificity of 100%. Again, it included this detection of the RHD pseudogene and RHD-CE variants, which was present in 3.3% of RHD negative pregnant individuals in this study. And then it said that it obtained results with fetal fractions as low as 1.1% and as early as 10 weeks gestation. So then there was another study that came out in July of 24 Again, the authors, many of them are employed by billion to one. But they looked at concordance to neonatal outcomes. So this was a diverse, multi-center prospective cohort from 120 clinical sites in 37 states across the US from September of 2022 to December of 2023. The aim was to identify individuals with pregnancies at risk for hemolytic disease of the fetus and newborn to guide management. And how did they do this with this next generation sequencing based technology that we just briefly discussed? And they looked at a number of antigens, including RhD. And patients were alloimmunized pregnancies undergoing clinical fetal antigen cell-free DNA analysis between 10 weeks and 37 weeks were included. And then after delivery, neonatal buccal samples were sent for antigen genotyping to an outside lab that was blinded to the cell-free fetal results. There were 156 participants and neonates that were enrolled, and they were alloimmunized to 101 antigens. The median gestational age at the time of testing was about 16 weeks, and the median fetal fraction was about 11%. Overall, there were 91 fetal antigen results that were reported and they essentially found that there was concordance for 190 fetal antigens to which the patients were alloimmunized. And this, I mean, so basically they were looking at all of these. The one that we're talking about is D. And concordance was assessed for these 190 alloimmunized antigen calls from these 155 patients. If you'll remember, there was initially 156 patients. So there was one case that had fetal cell-free DNA results, but was inconclusive on neonatal RhD sequencing from the outside lab. So they simply just didn't do a concordance assessment. And complete concordance between prenatal fetal antigen cell-free DNA analysis results and neonatal genotypes for the 465 calls resulted in 100% sensitivity, specificity, and accuracy. So we could really dig into each of these studies. Obviously, we don't have time, but they could each be a journal club in and of themselves. But that was billion to one's technology and the two major studies that were done that looked at that technology. And in the short, basically the importance is they claim that they can detect these other genes that are common in other populations besides a white European population. So then we have Natera. So like I said, if you've gotten the Green Journal recently, you've had this glued to the front of it. So Natera began marketing their fetal RhD NIPT in the US. They state their test is backed by the largest clinical validation study in the US and demonstrated 100% sensitivity and 99.3 specificity. It's a SNP-based cell-free DNA screening. They had a late-breaking poster presentation at ACOG in 24 at the annual meeting. The study has not been published in a peer-reviewed journal, but we have this, and this is what we'll look at. So it was a cohort study. Their aim was to determine fetal Rh status through use of Natera's next generation sequencing cell-free DNA technology. They don't get into the details of their technology. Again, it wasn't a published study. This is just a poster. The methods were 655 Rh negative patients per serology from March to September of 22. They used the SNP-based aneuploidy, cell-free DNA aneuploidy testing. Samples were retrospectively identified. And then maternal and fetal RhD genotype were prospectively analyzed. And they targeting RhD positive, RhD negative, RhD hybrid, and the RhD pseudogene. And then the cell-free DNA results were compared to serologic results for both mom and baby. And again, like billion to one study, investigators were blinded to the fetal Rh blood type. This is just demographics. The average age was mom was 32 weeks. The average gestational age at the cell-free DNA screen was 12 weeks. We see that 74% of patients included were white, 7% were Black, 2% were Asian. So results. Cell-free DNA fetal RhD was reported in almost all of the 655 cases minus 2. So 2 cases were no calls. All of the cases that were Rh positive are correctly identified. And then almost all of them correctly identified Rh negative fetus. 2 did not. So importantly, there were 0 false negatives. And so the assay was 100% sensitive. There were 2 false positives, sorry. And there was a 99.4 positive predictive value, 100% negative predictive value. And then of note, 3 of the Rh negative fetuses had pseudogenes. So not a large number, but there were a few.
The no call means not enough sample.
So we don't know what that would have been.
But they were not included into the equation.
And that was the
should
same,
have.
and that was the same problem with billion to one, is only the ones that were concordant were included.
Yeah. You still live into cases where you're not informing, so they should have been included.
Again, has not been published or. So their conclusions, they claim that this is clinical validation of the cell-free DNA test in a large cohort of Rh negative pregnant patients, and it demonstrates accurate prenatal identification of fetal RhD genotype. An assay performed with 100% sensitivity, and that early identification of fetal RhD genotype can assist patients and providers. So then following this, in June of this year, ACOG released a clinical practice update that clarifies guidance on paternal genotyping and provides new recommendations on the role of non-invasive fetal red blood cell antigen genotyping in cell-free DNA. And so this is what they say: non-invasive fetal red blood cell antigen genotyping using cell-free DNA isolated from maternal plasma has emerged as a reliable alternative to invasive genetic testing in the setting of maternal allo immunization. Because cell-free DNA testing process possesses performance characteristics that appear comparable with those of molecular testing while avoiding the rare complications and costs associated with diagnostic genetic testing, it is reasonable to use it as an alternative. And then there was a clinical opinion piece that was published in AJOG by Dr. Moyes, who's actually on the advisory board of Billion to One, who is saying that this is where we're headed and this is what we should be doing. And he creates an outline of how to essentially use this. And so he says, order the cell-free at 10 to 12 weeks. If the result is negative, RhD result is negative, then there's no need for RhIg. And you can confirm the fetal status at time of birth. If it's positive, then that changes what you do. And this is just another schematic of him, from him, that further goes into specific steps. And just of note, there's actually a guideline at UNC that's like somewhat similar. It's created by Bill Goodnight, who's the medical director of their fetal care center and leads their fetal program. But essentially looks at paternal genotype to kind of determine next steps. And so the first thing you do is get paternal genotype, assuming you can do that. If it's heterozygous, we know that there's a 50% chance that the fetus is RhD positive. And so that's when you can, that's how, this is the protocol that they use. That's when they would use cell-free DNA to test for fetal antigen status. And so potential benefits of NIPT for fetal RhD. genotype analysis, obviously it can guide necessity of program administration in Rh negative patients. It could decrease the usage of unnecessary administration. It could offer management strategies in alloimmunized pregnancies, which of course may prevent unnecessary fetal monitoring. It can lessen patient anxiety, but things to consider. One, is there enough clinical data from a diverse population to support its use? Because again, it's the diverse population that's important. Should we only be using cell-free DNA for RHD status during shortages of RhoGAM? Should it be utilized only in certain clinical scenarios? So for example, what UNC does, where they only obtain it if dad is heterozygous genotype for RHD. Should it be offered? And this is something that I watched a little one of Natera's sessions that they did on this, and there was an open Q&A at the end. And one of the questions was in regards to this, that it's currently, both of these tests are currently in conjunction with the cell-free DNA for aneuploidy, and should it be offered as just a standalone test? Because maybe patients don't want that information. What's the cost? And then what about the use for other red blood cell antigens? So as we saw in like the Unity study, they didn't just look at RHD, they looked at many other red cell antigens and the use for in those. So these are my references. But
In the poster that you presented, 75% were white women.
Exactly.
So this is a test for white people.
And that's why the question is like, did we really, yes, we finally tested it in the US and we acknowledged that, the tests that were done in Europe, we're only looking at deletion of the RHD gene and not the other genetic variations that can occur. Great, check. But did we have a large enough group of people that we did these studies in, and were they diverse enough to really be catching all of the different potential variants? And I think that's.
If the lecture says there are ongoing prospective studies on different populations, Black populations, Hispanics, Indians, Chinese, or Asians in general, different types, because we have people coming from all over the world. We have a lady with a ovary problem. See, we have the difficult ones that we don't know how to react. And we have mixed population because we have a lot of mixed racial parents with all sort of combinations. And now this baby is in a mixed race situation that we don't know what to do.
I mean, I think UNC's approach is reasonable to me, where you're incorporating it once you know maternal genotype. But not just as like a standard, everyone that's Rh negative, send off cell-free DNA for RHD status. But
It's like a deletion, then
exactly.
pseudogene. You don't have that.
Right. I mean, they're claiming it works, but it's just such a small number.
Such a small.
And
I mean, there were 3 cases of a pseudogene.
What about in the
But-
the billion?
The 1,000,001 Unity.
Yeah, do they break it down by pseudogene, hybrid, and deletion?
I'm sure they did, and they claim that it works for those, but I don't remember off
They're
the
also
top
like
of my
such
head how
different
many they were.
technologies too.
They would honestly be interesting studies to like really do as a journal club and look at.
Yeah.
It's a lot to try to put in today, but.
I mean, my 2 cents would be like, even in this room, instead of us, at least half don't have European. So, you're looking around the room, which is a great thing. But on the other hand, I remember where cell-free DNA came from in NIPT, it took a while. I mean, this is just a matter of time. As the technology increases, improves, I think this will become standard. The question is it now or is it in 2 years or whatever? But I think given the fact, again, I'm not an expert in this field, but given the fact that there's now multiple companies, major peer-reviewed. I mean, some are peer-reviewed publication. You can argue, ChemOIS is like sponsor, but we changed Eutrophilac because of a lecture he gave 15 years ago. So he's been an expert in this field for a long time. So I actually feel like you do, Keely. I think that UNC approach will be something that we could.
A starting point.
With the starting point tomorrow, here, I think that there's probably, close to enough data. I'm sure, if a lot of other places are doing it, more data is coming out. Again, I know Europe is different, but I'll tell you, for example, in Italy, 20-25% of births right now are not Europeans, come from North Africa, Far East, like, Ukraine, Russia, whatever, Asia as well. So, France has a huge non-European population. So I wouldn't, there must be some diverse population in those European studies as well. I think, it will be so much better than doing an amnio, I think it would be crazy to do an amnio this day and age given this data. And even MCA, you're doing tests every week, every couple of weeks. Why? The only thing with the UNC approach is paternity, to me, because as we know, many studies, it's really hard to
Assuming.
do paternity. And I'm sure there will be some cases that you wouldn't detect it, but I would think with an approach like this, there will be. For my 2 cents, but I think I'd be positive for a change. It'd be a lot of work, This is 15% for us, to try some birds. So that 450, 450. But we should test the father routinely, on those pregnancies anyway. So that wouldn't change what we're doing
And
now.
I think what stinks is just like the logistics of it, because I feel like often, obviously we recommend it, but I don't know how often it actually gets done.
Right, but in an evidence-based world, like we try to practice, this maybe will be an incentive to do that routinely. Test of 450. I guess by your data, 40% would be homozygous, and then there's no need for this. So there'll be, whatever, 150, but it'd be a couple hundred more pregnancies in which you would send the cell-free DNA. So it's something that we would do almost on a daily basis, but it wouldn't be undoable. What do you think on the genetic counseling side? Is this doable with this company? Is it too cumbersome?
I think just from my experience and what I've looked into for 1,000,000,000 versus Natera, I just trust Natera and their technology. And however, of course, the study is showing it's not, a diverse population, but thinking more so from a social and patient supportive standpoint, especially coming from Temple, we did offer 1,000,000,000 for the recessive conditions because father wasn't in the picture, wasn't available for testing. So I could see how if you're able to offer the cell-free DNA for RH, because you can hear sometimes it's like pulling teeth to get partner testing. So to be able to provide that information concerning the pregnancy could just, does that outweigh the possible, drawbacks from, but I think
At least you're getting some
you're
information.
getting some information.
And you would think that we could, does it depend on insurance? Or you will go just with Natera given their track record?
I am a little bit of a lab loyalist. I trust Natera a little bit more. I think 1,000,000,000 I've have done a little bit of digging into, and I'm curious to see how this technology evolves. So I think it's an interesting technology, something different for sure.
But insurance would.
But insurance, Natera is really good about insurance.
So if we started tomorrow, you think most patients would?
In one of their little sessions that they did, we have to look into this, but someone asked about cost, and they were saying that you can add it on to a cell-free DNA test that's already been done and they're not charging.
And that's the thing though, is like when these labs start offering these tests, they often, don't, charge patients just to get it kind of going, but then that also makes me think later on down the road, are they going to be depleting, their resources? Is it gonna be like a sequinome sort of situation where we run out of funding and we can't provide this like testing at no cost for?
I mean, the other way to think about it, I don't know if I'm being naive here, but we're offering cell-free DNA to more and more people at 12 weeks. We do fairly well, we have a process in place and stuff. Why on those 450 pregnancies that we say when they come in at 12, like why don't we check Rh status on every 12-week NT scan and say if she's Rh negative, if there wouldn't be the North Carolina, but we could offer it to, we could add it to the cell-free that we have, so we don't have to do another blood test. I mean, that's another way.
So the European studies did Africa. And then the billion
Many of them.
one was.
The average was 12.
Oh, the average was 12.
Medium.
And then the Terra one was early.
So I also kind of wanted to chime in a little bit. I do agree that I think that the UNC approach does make sense, of course, with the limitation of paternity status, which of course is I guess always a concern, but in particular in this case, something that we would of course want to consider due to the fact that it's not definitive completely. I also agree with Claire that from my experience that Natera is a far more reputable lab than Billion to One. However, I do have some concerns. They are great when you have patients who are uninsured. They are great when you have patients that have Medicaid, but I from my understanding that this type of testing would not be covered by insurance for patients with private insurance. Certainly, if they have already had NIPT that was done through the lab and it being added on, that sounds like like to get it going, that'd be a non-cost, a non-added cost. But I think I would have qualms about those with private insurance. And then lastly, I think Dr. Roman mentioned this earlier, is that just one of the issues that I've always had with Natera, again, I think that they're a great lab and many centers use them. But I've always had an issue with how they represent their data, because I find that they, among many other labs, have a much higher no-call rate in general. And I do think that's how they're able to maintain their high metrics with sensitivity and specificity.
MFM is going to come out with a guidance very soon on what to do with in the setting of RhoGAM shortage now. And so it's going to be.
I'm sorry to interrupt. I think RhoGAM shortage, it's a ridiculous thing. Like, I understand that it's there, but if this is better, who cares about, you know what I mean? I understand that it's part of the decision, but I cringe on the fact that this technology has been around for so long, and we waited on shortage to, like, you know what I mean?
Well, yeah. So, there's a comprehensive consult series that's going to be coming out, but that hasn't been made yet. And then because of the shortage and members were asking about it, we're doing this interim guidance.
Mhm.
And it's written by Sparks and all the genetics people, and then they essentially, there's a lot of debate, but it's going to say do as a single test, can consider. It's a reasonable consideration when you have Rh shortage and you're testing for a non-alloimmunized patient. If you were to do that and they agree to that, you have to document that there's still that potential small risk of false negative and sensitization, and then repeat the screen at 26 to 28 weeks in that setting. If then it goes from negative to positive, talk about amniocentesis.
Repeat the cell-free?
No, the type and screen of the patient.
Okay.
And then if there's potentially a positive, then amniocentesis, talk about, or testing or whatnot, and go from there. So it's going to be online, hopefully. So we just reviewed it, and it's like expedited.
So it's going to be more on the pro side, you think, or?
Well, they acknowledge the limitations of the existing data, European technology, an abstract that hasn't been published, peer-reviewed paper yet, and limitations of expanded to like other African ancestry and things like that, and that the data from even the NIPT study was only limited to what 100 and something individuals. So it doesn't seem like they're so pro it, but being in the setting of a shortage, and they said if you're not a shortage, they said there's a document that's going to be coming out and whatnot.
I
So
think
wait,
the irony is we're supposedly coming to the completion of a shortage. Cause they said by the end of, it's just gonna last to the end of 2024. And
Okay, yeah,
it's
exactly.
September, and it's not out yet, and like.
And we haven't had any issues at Jefferson, right?
We haven't had any issues.
Yeah.
But don't ask me, I thought we used Rogam, so.
No.
But program is not cheap either, it's about $300 per vial.
Well, now there's no cost analyses have been done on this new.
and then and remember, no calls were not included in that NIPT study. So they just are acknowledging that
It's not
there's
perfect
some
data.
like, yeah, exactly.
I wonder why the paper is not published, it's been several months.
I guess, you know, one decision we could make is to wait
Oh,
for
for that one.
SMFM guidance as well, to be, you know, to be consistent with everyone. Huda, are you listening in?
Just give me a lecture.
She's still doing lecture review after
I
10?
could see an issue with implementing, say if we were to like flip a switch and offer it tomorrow, thinking about our patients that elect sequential screening versus cell-free, then they might be like, well, why am I not just doing cell-free, like for all of my screenings if I'm gonna be doing it with that? Then we could be potentially missing, you know, some of the.
But that's why it's important to acknowledge that at least SMFM is saying consider it as a single test and not.
It's just,
one.
it's not currently offered that way is the problem.
Yeah.
So then you're basically saying don't use it.
It was when it was Sensagene back when Sequinome was doing it, but unfortunately they stopped offering it, like you mentioned, because it was no longer cost effective for them.
Yeah, it says should be available as a single test due to the financial, medical, and ethical challenges of combining RHD genotyping and aneuploidy screening. Labs should make it available.
I just want to show everyone.